Hey. Hello. Hello. Good. Wow. Awesome. I've given a bunch of talks over the years, and they usually ask me to come up with a topic and make slides and all, and I have a whole bunch of canned talks. But when I give talks, at the end, usually there's a segment of questions and answers, and oftentimes that runs over the allotted time. So I thought we'd just start off with Ask the Doctor today and take questions from the audience. And if I know the answer, believe me, I'll tell you. If I don't, I'll tell you I don't know, because I don't know everything. I didn't make 100 on every test in medical school. So I'm from Lake Charles. I was born actually in this hospital, and went to McNeese and finished up at LSU in New Orleans. So an orthopedic surgeon, basically we do bone and joint surgery, bone and joint non-surgical treatment for disorders, either pain or instability or deformity. So all the bones except for the head bone. Most orthopedic surgeons who do spine work do a few years extra specialty work. So the average orthopedic surgeon doesn't do spine work unless they've had extra training. But even with orthopedic training, a lot of us do a little bit of extra training. So after I graduated from LSU New Orleans, I spent a year in Philadelphia at the University of Pennsylvania doing some specialty orthopedic surgery work with what's called the arthroscope, which is a little tool to look inside joints and to do work without having to make the big gigantic incisions. So, right now my practice has changed over the years. So the first 10 years of practice back here in Lake Charles, I did a lot of trauma, a lot of accident work, a lot of emergency room work, car accidents or falls and broken bones. The next 10 years, I did a lot more of the sports stuff, a lot of high school athletes, and did some work with the college athletes. And my next 10 years looks like it's going to be focused more on joint replacement surgery. I do currently hip and knee and shoulder replacements. They do have other joints that can be replaced, but they don't really work out as well as knees and hips and shoulders. And the other thing is a lot of the other joints are arthritis is relatively well tolerated. For instance, people who have arthritis, say in their elbow, don't have the same disability that those who have it in their shoulders. Same thing with the hips and the knees. It just seems to be more disability with those joints. Limited motion, limited activities, can't get up, can't walk, that sort of thing. So who in here has had a joint replaced? One? Yeah, I know you've had one. 2, 3. So, yeah, and everyone's experience is unique. We all have the patients have different experiences. So patients will oftentimes, one of my favorite questions they'll ask me since we're here is, how long will it take me to recover from my surgery? That's a super common question. And back when I did a lot of trauma, it was a bit easier because I knew that certain bones would take so many weeks to heal, or certain joint injuries would take so many months to heal. But a joint replacement is a bit different. And every person has a different idea of what it means to make a recovery. For instance, if someone comes to me and they say, how long will it take me to get, how long will recovery take? They may want to know, what they're really asking me is, how long will it be before I get back to work? Or how long will it be before I don't have any pain at all? And those are two very different things. So when you look at a joint replacement, that's what we call an elective case. It's totally elective. In other words, you're not going to die from having a hip, you're not going to die from arthritis in your hip or arthritis in your knee. Where before the first 10 years, when I took care of broken bones, I mean, those are some serious problems. The patients, it's not elective. If someone's in a car accident, it's an emergency, right? Whether they like it or not, they're going to need something done. Kind of the same thing with the sports stuff. A young man or young woman injures their knee and then they can't do the sport they wanted to do before. They're going to want something done right then. Who's had a sports injury or had a child or a grandson that's had sports injuries? Yeah, you've been through that, so there's a lot of intensity to get something done right now. Whereas hip and knee and shoulder arthritis or those types of surgeries for those arthritis, you don't really need to rush into it. So you should give it a lot of thought. Questions on that? This is Ask the Doctor, so.
I had an MRI. The orthopedist told me both of my shoulders are blown out. The right one worse than the left. 6 weeks in a sling. I'm 75 years old. Live alone. And I have 3 dogs. A mobile home, a yard. Okay, so a friend of mine went on the internet, which I'm not internet.
Love the internet, right?
She said to me that there was, all she Googled was something like shoulder replacement. And it said that before you make that final decision, read this. And she only mentioned one thing to me. It was something about stem cell, something or other. Do you know what that's about?
Okay, that's a great question. So I'm going to summarize your question because it was a little bit all over. Rather than answer your specific shoulder issue, one thing that is in the news, and the latest and the greatest, is stem cells. Who's heard of these things? Everyone? Yeah. Okay, good. So let me explain what a stem cell is. So a stem cell is a cell in the body that has the potential to become specialized cell. So think of it like this. When an egg and a sperm cell get together, they make a single cell baby, right? And then that cell splits, and the 2 cells are identical. Then it splits again, you have 4, and it goes on and on and on until you got this big ball of cells, and they're all pretty much the same. And then eventually it kind of folds on itself and makes a tube, and then eventually it makes the baby. Well, somewhere along that pathway, whether it's hormonal or what type of signal is happening in that individual, those cells that used to be all the same gets a signal that one cell decides, I'm going to become a nerve cell. And then another cell gets a signal that says, well, I'm going to become a muscle cell. And that's how those cells determine what type of cell they're going to be. We don't know the mechanism, but we know that it starts with this thing called a stem cell. And that's the name that's been given to those cells. So believe it or not, you have in your body some cells that can be told what to become. They're still in there. There's still some in there. You can get them from bone marrow, and you can get them from fat. There's all sorts of sophisticated ways to separate out these cells. Okay. So a lot of the research in stem cells came about with leukemia and lymphoma and that sort of thing. So what they would do is wipe out someone's bone marrow and then put stem cells in, and those stem cells would become natural bone marrow cells, natural cells that would produce blood cells. All right? And there's a lot of research in that area, and a lot of it's really good. But it doesn't really work that well for joints. I've actually done some research out at McNeese with that. Took some pigs, artificially gave them arthritis, and then injected stem cells. The difference between bone marrow and a joint, or say skin, where stem cells are used in skin for grafts, is that the knee or the joint, especially the knee, is a desert inside. You should think of stem cells as little seeds that can be put in an area and made to grow into whatever's in that area. But the knee is a desert. You're essentially throwing these seeds out on concrete. Now, one day that situation may change. We may figure out how to cultivate those seeds inside the knee. But right now, the vast majority of research that's done in stem cells in people's joints, and I'm not talking about the laboratory, but I'm talking about in the joints, does not show that there is cartilage regeneration. Now, people will have these shots and they say it makes them feel better, but I'll tell you, those joints continue to deteriorate. The other thing you should know is that these stem cell injections are not covered by any insurance company, they're not covered by Medicare, and they're usually very expensive cash payments. Yeah. I don't do any of that stuff. I mean, my personal research and my personal experience has been negative on that. And I think it's fine if someone wants to do that, but I'm out for now until I see something that's substantial. So, did I answer your questions? So let's talk about your shoulder, because I love it when someone says my shoulder's blown out.
That's the words that they
Yeah. So I'm not sure what that means. I'm not sure if it means you have torn tendons or torn ligaments,
Yes.
or if it's just.
I said to him, how come my arm is still hanging there? And he said, because he said my muscles and tendons are also ripped.
Yeah. Can you lift your arm up?
Oh, yeah.
Yeah. Okay.
And he said after I come out of these 6 weeks in the sling, maybe I'll be able to lift my arm like this, no further back. I have a lot of range of motion now.
Yeah, you do.
What's going to happen? I hate to lose some of that.
Mm-hmm. Shoulders are an interesting joint. I mean, first of all, they're the joint that has the most motion of any joint in your body. The amount of motion is incredible, really. And if you look at a shoulder, it's a ball and a socket joint. So it's got a big old ball on the end of the humerus, but it's got a little bitty socket, little bitty bony socket. It's almost like a golf ball sitting on a golf tee. So most of the stability of the shoulder comes from muscles and tendons. Does that make a little more sense? You know, if you look at a hip's got a big ball on the end of it, but the bone, the socket part, covers that ball. So the ligaments and the tendons and all that inside the hip are not as, they're important, but they're not as critical as the shoulder.
What do you do when you're doing orthopedic surgery and the person has bad osteoporosis? How do you insert pins or screws or so forth?
Yeah, great question. So I'm going to address, the question is basically, how does osteoporosis affect orthopedic surgery? Okay. So osteoporosis is a condition that happens to everyone. I mean, it's going to happen. When you are born and start growing, your body is building the bones. And it builds bones two ways. It makes collagen, which is fibrous tissue, and it's got calcium, okay? So you have these hard bones that are growing. And then over the years, about 30, 35 in everyone, you start losing that calcium. We kind of know why, but we're not real good at stopping it, okay? But it happens. And it happens faster in women because of the way the hormones work. So it can happen especially if they go through menopause early or they have a complete hysterectomy. They can start losing the calcium a lot faster. So what you wind up with is a normally looking bone. It's shaped normally. It's not abnormally shaped, but the calcium becomes leached out. So if you look at an x-ray or you take a bone from a young person, like 20, it's hard. I mean, that thing is hard as rock. Someone who's, say, 90 is much easier to break. All right? So, when someone breaks a bone and has osteoporosis, it actually heals about the same. It heals about the same time. The problem is if it's a bone that breaks that requires surgery, that you have to put pins or screws in it, okay? Those screws don't hold as well. It's like putting a screw in a piece of balsa wood instead of a piece of oak, okay? Now, there's a number of strategies to do to get around that. And those are very technical strategies, but there's things you can do to help that. From a joint replacement, in other words, the bone's not broken, but you have someone that has arthritis, say, in a knee, and they want to have their knee replaced. There are some limits, but for the most part, that doesn't bother me too much. I mean, you can put it in there, and they do pretty good. Am I answering your question? Mm-hmm. Okay.
The next question is, when you drill into a bone.
Yeah.
Okay.
This guy's great. He's technical. I'm loving this. He's probably in his backyard, got a shop in the back.
Correct. You get sawdust.
Yeah.
What? How do you get rid of that?
Okay. So typically when you drill in a bone, like you've had a big broken bone, you put in a metal plate with a bunch of screws. We just leave that bone stuff there. The body absorbs it. But when you do like a joint replacement, where you're taking, especially a knee, because there's a lot of bony cuts on a knee, you're cutting, and yeah, it makes bone dust. You get that bone in there. Now it's wet because of the fluids that are present in the knee, but you have to rinse all that out of the knee before you put the artificial knee in place. So we go to great lengths to ensure that all the debris is out of the knee. Let me explain to you a little bit about doing an artificial knee. So you cut the knee open, you open it up, and you literally, we can get into it later, but there's a certain pattern of cuts you make on the knee so that the new knee will fit onto the end of the bone, all right? When you make those cuts, it does generate this sawdust. And the inside of the bone has got a lot of fat in it, and there's also joint fluid around and a little bit of blood, and all that kind of gets mixed in there with that sawdust or bone dust, if you will. So once you finish the cuts and you're ready to put the actual knee in place, the way 99% of knees are put in the United States and probably around the world is to put this in with a glue. You use a certain type of cement. Who knows what JB Weld is? Yeah. So we use a cement that's very similar to JB Weld. I mean, it's not the same, but it's works fine in the human body. So you mix it up on the back table, and you want to put that on the surface of the knee and then place the knee on that glue. Well, you know, from everyone knows here, if you want to put something sticky or a decal on a window, you got to clean that window off before you put the glue on there, right? So we have to clean that knee off to get that glue to stick, the cement to stick. So we rinse it off and we dry it out as best as possible and put it on there. Now you can't use solvents, right? Because believe it or not, although we treat that bone like an old piece of wood, it is a living thing. The bone is living. So you don't want to kill the bone. That would be not good. All right? So once it's cleaned off and dried off, we put the cement over the surface. Take out all the excess cement, put the knee together, and we wait while it cures. After it's cured, that knee is solid. I mean, it is super. If you ever try to knock off JB Weld, you got to use a chisel to get it off, right? Same thing with that glue. Once that thing's in there, it's done. Now, as drastic as that may sound, once that knee is glued in place, it is solid. You could get up and walk. I mean, as soon as that stuff is cured, it's ready to go. So most people we do artificial knees on, we actually stand them up that same day and encourage them to walk and get up a lot the next day. A lot of therapy. And most people go home the day after surgery. Yeah.
I'm 81, and I might be called a snappy walker. because when I walk, my knee, my left knee, it pops.
Uh-huh.
No pain, but there's slack in there. And my question is, should I wear some kind of cushion or something to keep it closer together? But I'm in zero pain.
Okay. This man has another good question. I get asked this one a lot. So there's really two questions. One is, my knee makes noise. Is that a bad thing? And the answer to it is, joint noise is common. I would never get out of the operating room if I operate on joint noise. I mean, it is common, even loud popping and catching, as long as it is not painful. If it's not painful, keep rolling. Ignore it. All right? Okay. The next thing is, what about braces? From a medical, orthopedic, structural standpoint, braces don't do much. All right? I'm not a giant fan of them. But a lot of people get relief when they wear braces. So from that regard, if you're wearing a brace and it makes you feel better, go ahead and experiment with it. There's tons of braces at Academy or Dick's Sporting Goods or on Amazon. But from a medical standpoint, asking me to write a prescription for a brace, probably not a great thing, because if I write a script for a brace, now you're talking $1,000 for these braces. And I hate to see you spend that kind of money or go through all that and have it not work. It's a lot easier just to go to Dick's and get a $20 or $40 brace.
Well, when I was thinking something elastic to kind of take the slack out of it or whatever.
Yeah.
You know, like football players used to wear. I don't know what they wear.
They still do, but there's not a brace in the world that's going to prevent an injury for the football players. So.
Well, I'm in great shape then. I'm good for another 81 years.
I was hoping you'd say your knee was killing you.
I was reading between the lines.
Go ahead.
This doesn't have anything to do with joint or knee or shoulder, but I'd like to know if you have bunions, should you go to an orthopedic surgeon or a foot doctor?
You know, 20 years ago, most of the foot doctors didn't have a very good training in that, but now I think that most of them have pretty good training with bunions. And, yeah, I don't see much difference in it. Now, we have some very good orthopedic surgeons in town and some very good podiatrists. I mean,
But an orthopedic surgeon would work on a bunion.
if they have a little special interest in feet. I've done a few bunions, and
Are there any new techniques that make the healing time less? I saw something on the internet. A little tool that they were using now to make a very small incision. I don't remember. It's some new technique that they're doing in California.
yeah, they do all sorts of stuff in California. There's a lot of things that come out that are new and exciting. But you got to realize that, you know, when you're doing orthopedic surgery or doing some type of surgery, my goal is that if I have to do it, I want it to last you the rest of your life. It's not something I want to say, oh, well, we're going to do this, and 2 years later we're going to have to go in there and do this, and 2 more years, this, that, and the other thing. So when I look at something new, I want to be sure. I'm skeptical. I have to be that way, because what I'll do, I want to have a track record for the patient. Because there are tons of things out there. You look at orthopedic literature, there are things out there that come out and they say, oh, this is the latest and the greatest, only find out it don't work, and those people have to have some major redo surgery. Who's heard of metal on metal hips? Okay, this is something that's small, but it turned out to be a big deal. They do these artificial hips. Okay, you take the ball out and you put a new cup and a new ball in. Well, they put a liner in there that's usually it's made of what's called polyethylene, which is a plastic. I mean, that's been working pretty well for the last 30 years. Well, they came out with this thing that said, we're going to put a metal liner and a metal ball, and it's going to be even better. Well, it failed miserably. And the patients had metal ion disease, and there's all these questions of they're going to get cancer, and they had to have repeat surgery to take it out and put a new one in. I mean, it's a disaster. So you have to be careful about new things. Research it. I wouldn't fly out to California to have it. I'd talk around and, get some good opinions on it. You got to watch it. I mean, some people are doctors and they're also a bit of a salesman. Like stem cells, they're trying to sell you something. You got to be careful with it.
Well, how long would a traditional surgery on a bunion take?
How long will it take? Well, I haven't done one in 20 years, but it takes about 45 minutes each foot. And they do a lot of them bilateral now. You walk around and they do pretty well. The thing about bunions, though, if you look at a society where they don't wear shoes, they don't have bunions. All right? It's the shoes. So if someone has bunion surgery, you can't go right back into those same high heels because it's going to give you, your bunion's going to fail.
Can you tell me what actually a bunion is?
Yeah. Well, I'm not taking off my shoes. We're on TV here. But if you look at the foot, it's where the first toe moves over and you get a big knot right there.
Oh, yeah.
Mm-hmm. And all sorts of things can happen when that gets going. The second toe can overlap the first toe, and it can really be an issue.
Talking about little joints, I don't want to take up much time, but
Hey, I've got another 30 minutes. Keep it going.
Arthritis, a little short thing on arthritis. What causes it? What is it?
Okay.
I know what it is, but not really.
Well, arthritis, if you look at a bone, the bone's solid, hard, calcium like we talked about before. But where a bone meets another bone is a joint. There's all sorts of different types of joints, but the ones that give us problem are the joints that move a lot. And where the bones meet, the end of the bone is covered with a special tissue called cartilage. And this tissue is called hyaline cartilage. There's different types of cartilage, but this is called hyaline cartilage. And that stuff is precious. Once it's gone, it's over. If it gets damaged, you can't stem cell it or whatever. It don't work very well. Once it's gone, it's gone. You can't get it back. Okay? So when that cartilage wears off for whatever reason, then it's bone on bone, grinding, popping, catching. Feels like it wants to come out of place. All right? That can happen in any joint, and there's all sorts of reasons to make that cartilage go away. There's really two major categories of arthritis. There's what they call rheumatoid arthritis. You've heard of that, right? That's what's happened in rheumatoid arthritis is for some reason the body's immune system is attacking that cartilage. Just like it would a germ or a bacteria. It attacks it and eats it up. So there's also, you see it on TV today, there's psoriatic arthritis, rheumatoid arthritis, you see all these advertisements for these medicines, and they work. They work great. They shut down that immune system. So you got to be careful not to get an infection while you're on those drugs. But by far the more common arthritis is what's called degenerative joint disease. Runs in families, all sorts of different reasons for it. Could be overuse. We're not really sure about a lot of it. But think about degenerative joint disease as basically the tread wearing off the tires. That cartilage just gets worn off. That's the easiest way to think about it. And that's the most common.
Is there anything you can do if your knee starts hurting to make it decrease or extend the life of it, exercise?
Yeah, keep from having to see me. So he's asking me what can be done, some home remedies for knee pain. Okay, in the absence of injury, if your knee hurts, and even if you do have a small injury to your knee starts hurting, starts swelling a little bit. The things you can do at home is anti-inflammatory medications over the counter, like Advil or ibuprofen, the best. Just follow the directions on the bottle. Ice can help, 20 minutes on, 20 minutes off, and rest in it. You don't want to go out and try to mow your grass when your knee's hurt and you're just going to aggravate the fire up. Then you'd definitely be in my office. And if those things aren't working, oftentimes a cortisone shot can handle it. I mean, I give out a lot of cortisone shots before I do surgery on people. Sometimes even physical therapy and brace can help too, when I've heard mention braces. Those are some things you can do at home to help you. Now, I said all that as long as your family doctor is telling you, as long as you haven't been told not to take anti-inflammatories. If someone's on a blood thinner, probably shouldn't take anti-inflammatories, right? If you have heart issues or whatever.
Cortisone.
Mm-hmm.
I'm made out of cortisone.
Yeah.
I have shoulder problems, and fingers, and I've had at least 100 cortisone shots.
Mm-hmm.
The doctor that I used to use, is now deceased, believed that didn't matter how many I got. And other doctors tell me, no, if you've had one a week ago, you can't get another one.
Mm-hmm.
So what's your feeling about cortisone shots?
Okay. So what happens when a joint has, he's asking me how I feel about cortisone. Tell me a little bit more about cortisone injections. So if you have a joint that has either rheumatoid or even regular old arthritis that becomes inflamed, well then it's got a lot of fluid. The inflammation causes pain, swelling, right? Losing the motion in it. There's a number of ways to reduce that inflammation. One way is the ice. The other way is oral medication, like we talked about, the anti-inflammatories, the ibuprofen. The other way is to do a cortisone shot. Okay. Now, you could also take oral cortisone. That's another option. The problem with the oral medications is that you take this pill and it goes all over your body, right? The medicine gets in the bloodstream all over your body, which helps. But when you do a cortisone injection, you're putting a concentrated dose of that material right where it needs to be. The other thing about cortisone injections, there's very few side effects from the injection. If you take oral cortisone, you're going to know it. It can hype you up, it can make you feel bloated, feel like you're gaining weight, keep you from sleeping at night, and it's going to have significant side effects. And there's a lot of other worse side effects that can happen if you take oral cortisone or prednisone for months. And it can cause some serious medical issues. So the benefit of a cortisone shot is that it puts that medicine right where it needs to be. Okay? So, why don't you just do it all the time? Because if you do it all the time, eventually it's going to cause those problems I alluded to with the oral medication. It can cause diabetes, it can cause bone death, it can cause serious issues. Yeah. Who in here is a diabetic? Okay. Who in here's had a cortisone shot and they're a diabetic? Did it make your blood sugar spike up? Yeah, it'll jump it. No.
You didn't answer my question.
I did too. I thought I did. Did I dance? I'm going to go into politics now.
How often can I do that?
Oh, how often? Okay. In general, I kind of keep it to about 3 to 4 a year. In one joint. Now, sometimes I'll fudge a little bit and, give them a shot in the shoulder and the knee and that sort of thing. I don't like to give more than 2 cortisone shots at a time to anybody because there's a limit to how much of this cortisone you can really load into the body.
Okay.
I mean, I wouldn't give a shoulder, both shoulders, both knees, and the hands. That's going to be a lot of cortisone. That's too much. You're definitely going to have some diabetic issues
Well, I can
or blood
put
sugar issues.
my finger directly on where it hurts, in my shoulder. And I'll tell the doctor that I'm using, that's where it hurts, that's where you stick me.
Uh-huh.
And my first doctor listened to me.
Uh-huh.
And the second doctor says, no, I know where to put it. And so I say, okay, you're the doctor, you put it where you want. And he does.
Uh-huh.
So who's right? He is, probably.
Without examining your particular case, I'm going to punt on that one. I'll have a lot of people say, give me the shot here, and generally they're in the correct area.
Yeah.
Now, a lot of people will have pain up in the shoulder and the front, but I prefer to give the injections in the back because it hurts a lot less. I mean, I can give the injection here, it doesn't really hurt. If you give it here, it's very painful. But I use a really long needle back here, and it reaches the front. Go ahead.
Arthritis in the hip, does it cause the back to hurt?
Yes, it can, and the reason it does that is usually because of the abnormal gait. You know, they're limping around so much. They're getting the abnormal. They're using their back, lumbar spine more to move when they're trying to take a step. Let me talk a little bit about hip pain, since you brought this up. Believe it or not, most of the time when someone has arthritis in their hip, most of the pain is right up in here, in the front. Okay? They do get some pain around in the back too, but most of the pain they'll complain about is right here in the front. If you have pain in your butt cheek, over in here, this area, most of that's probably referred pain from your back. Could even be a pinched nerve causing that. Pain on the sides right here on that hard spot, like if you can't lay down, or if you lay down and it hurts, or you're having trouble getting up and down out of a chair, that's usually what we call bursitis. There's a little muscle and tendon that rub right on that hard spot, and that can become inflamed. And that can be, it's a little bit worse in women, and it can be treated with just a simple injection, and usually that clears it up right away.
Okay, if you put cortisone shot in the hip, it goes into the hip for arthritis in the hip? Or is it injected into the back?
If you have arthritis in your hip joint, you see it on x-ray, you see it on MRI, and you're having pain in the groin, then you want to do this shot in the hip, in the front. And most of those shots are done under what's called fluoroscopy, because it's easy to hit a knee joint just by looking at it, but to get into the hip joint, not so easy. Plus, there's a lot of nerves and blood vessels in that area. You don't want to make a mistake. So most of the time, doctors don't do that in their office unless they're using something to guide the needle. Now, if you give a hip joint injection here, or hip injection here, that's not going into the joint. That's going into the bursa right here. To do an injection in your back, in your lumbar area, that is generally for degenerative disc disease of the lumbar spine. Okay? Did I answer your question?
Yes, sir.
Okay, good. Whew.
Can you do Durolane injections in the knee, and how long you can have those, or how many years?
Ask that again, please.
The injections in the knee, I think it's hyaluronic acid.
Yes. This man is asking me about a particular type of injection in the knee that is, the medical term for it is viscosupplementation. There's many different brands. There's Hyalgin, Synvisc, Euflexa, a bunch of other ones. Has anyone had one of those shots before? Yeah. What they're doing, the doctor's doing there is they are taking this material that is a naturally occurring molecule inside the knee, and it's basically a lubricant. It's a lubricant. So they're putting this material in the knee, and the thought is adding more of this lubricant will make the knee feel better. And it works. I don't mind people trying it, but it's not something that I push a lot for a number of reasons. First of all, that stuff is expensive. It's about $1,000 a knee for one treatment. All right? And there's different ways to do it. You can give one shot. There's some brands that are one shot, and it's $1,000 for that shot. And there's some other brands that are 3 shots or 5 shots, and each one of those shots is it's over $200. Now, having said that, I have some patients who swear by it. I mean, there's a small group of patients I have, and I've been seeing them for years. So I think it's worth a try if someone is exhausted everything else and they're thinking about having, do I really need a knee replacement, or I'll give them that shot and see how it works. The other thing is, if you look at someone in their symptoms and you're looking at an x-ray where the knee is completely destroyed, and it's just, you're kind of kicking a dead horse at that point. You're just wasting their time, spending their money. Sometimes it's better to recommend having the surgery. And the reason I will recommend having the surgery is to get the patient out of pain, right? That's the reason to have the surgery. Get them up and moving. Because anyone who has had enough pain in their hip or their knee or their shoulder to have surgery for it will tell you that it's not just the pain. That joint is dragging their whole body down. I mean, it affects their whole life. They're not exercising. They're not getting their heart's suffering, their lungs are suffering, and let me tell you what, their brain suffers. It's depressing when they can't get up out of the chair and they hurt. So sometimes you guys just throw in a towel and get the surgery done. If someone is healthy and there's no reason for me to recommend the surgery, I've had a lady who's been on it for almost 10 years. I mean, she swears by them.
With those shots, if you thought the stem cells would be beneficial, would they affect the possible benefit of stem cells?
There's some research where they're doing both injections and nothing positive has really come out of that. And when I say positive, yeah, the people may say they feel better. I don't know the answer to that. But I have several patients who have gone off and had those stem cell injections. And I'll see them beforehand, and I'll take an x-ray of their knee, and they got arthritis. And they'll come back 2 or 3 years later after having those stem cell injections, and I'll take another x-ray of their knee, and their knee is worse. I mean, it's definitely, you can see it's visibly worse. Now, don't tell me that those things work. Now, the patients may say they feel better, and I'm not saying they don't, but there is some placebo effect to that, and there's also an effect when someone's paying $20,000 for these injections that they're not going to say the knee still hurts.
What do the amnio cells that they give with the stem cells, does that help with? Or?
That is essentially the same thing from a layman's standpoint. Basically, they're taking some amniotic fluid with cells in it. The difference is those cells are not coming from your own body. Okay, those are off the shelf.
And it's supposed to improve the effect of the stem cells or make them grow better? Or?
There's nothing that's going to make it grow better in a knee or a hip or a shoulder, in my opinion. You got to get in there and turn that soil and put fertilizer, do something to make it grow. I mean, I'm serious. If you look at a knee that's really got bad arthritis in it, you're looking at bone is dang near look like concrete. I mean, it's smooth, it's slick. You put those cells on there, you're just going to float right off. There's nothing to make them stick. I wish there was. I mean, it'd be easy, right?
I get on an elliptical machine. I'm 69.
Mm-hmm.
And one of the things I see all the time is I go to one of these health places or whatever, and I see these guys with both knees operated on. They done changed all their knees out and everything else, you know. And I've never had that done. I wear some of these, it's a knee stabilizer with the Velcro.
Mm-hmm.
And I'll get on an elliptical machine, and I'll do an hour and 5 minutes, burn 600-something calories, do 5.5 miles, over 5.5 miles, and never feel them. But if I come back and I notice that one of my knees will kind of hurt me sometimes, so I started wearing them on both knees, and I've never had a problem after that.
Mm-hmm.
So basically, that's helping this thing, or what?
In your mind, that brace is helping you, right?
Yeah.
I mean, that's what you're telling me.
Yeah.
So keep wearing them. I mean, if that's what you honestly, from a medical standpoint, it's probably more genetics. You know, the buddies you know whose knees wore out, is probably just in their genes. It just didn't last.
Yeah, like I said,
Now-
I just don't have all the pains and stuff.
Yeah,
that-
which is great. Yeah.
And then I'll pump it up to 10, you know,
Yeah.
resistance. And when you burn 607 calories and do 5.5 miles, you know, straight in an hour and 5 minutes, you know. And I do other things. I do stretching exercises. But I see those guys come in there all the time, man, with their knees cut open and all that stuff, you know what I'm talking about? I say, well, I want to try to avoid this, you know what I'm talking about? So that's,
Well, the exercise you're doing is not helping the knee joint surface. I mean, that much exercise is probably detrimental to the actual knee. But the reason it's lasted that long is probably more related to just the way your body is, your genetics, what you inherited from your family. I mean, did mother or father need joint replacements?
no.
There you go. So it's not something necessarily that the brace is doing. It's not something necessarily that you're doing. It's something that's coming from genetics, which is great. You know, maybe that's the future, you know, finding something we can do with genetics to keep people from having to need surgery.
Yeah, I'll
Yeah.
just talk to those guys, you know, talking about it, and I'll see, you know, well, I had both of them replaced and all this other
Yeah.
stuff, you know. And,
Yeah, I used to do the same thing. I used to run marathons and get on the elliptical machine and pound it out and do all that stuff, and now my knees are shot. So are my parents. But, you know, when you're that age, you're going to keep doing it. Go ahead.
When you do your knee surgery, when you do surgery, what type of surgery do you do? Robotic or the regular?
I do the regular surgery. She's asking me, do I do robotic surgery? That's the new buzzword, is robotics. About, I don't know, 4 or 5 years ago, we were doing what's called computer knees, which is almost very similar to the robotics. So there's some differences, and most of there's a little bit of technical stuff. But rather than getting all into that, I'll just tell you my personal feeling on the robotic surgery. There is not a shred of proof, no matter what the advertisements say, that the robotic surgery is any better than a regular surgery. There is no literature that supports that. Okay? The robotic surgery takes at least twice as long as a regular surgery. And the longer that knee is open, the longer there is a chance for infection. There's plenty of studies that show length of time in surgery, infection rates go up. So an infection in an artificial knee is a devastating problem. It's a serious, serious, potentially limb-losing problem. So we stay away from that. All right? Like I said earlier, I want to see some track record before I jump on. Yeah. So from my standpoint, I'm not sure that's where we want to be. Does anyone know what the surgery is? I mean, when you do a knee surgery, you do the robotic surgery, you open the knee up the same way. So it's still the same surgeon opening the knee up. When I do the cuts, I use some mechanical devices to set the pattern of the cuts. And that's how I do it. There's all sorts of things you do with the knee to make sure you get the right pattern. With a robotic, the robot tells you where to cut. Okay? You're still cutting. You're still cleaning the knee and slapping that thing on there. So, for me, I don't do that.
When you say robotic, are you talking about arthroscopic?
No, arthroscopic's where you use a little tube that you stick into the joint and it gives you a big TV screen picture of it.
Do you do that?
Oh, yeah. Yeah, that's a big improvement over open surgery for certain things. You know, there's a lot you can do just by fiddling inside the joint rather than cutting it open and fiddling inside the joint. It's a big deal.
You do that often?
Which one, the arthroscopic? Oh, yes, sir. 4 or 5 times a week.
Is that orthoscopic? What are you actually doing there?
Okay. Have you ever heard he's asking me, what do you do when you do arthroscopic surgery? There's a ton of things you can do. So you ever heard someone say they tore a cartilage in their knee? Okay. What happens then is you get this little flap of tissue that's flipping around inside the knee and getting stuck between the top bone of the thigh and the bottom bone of the tibia. So one example of what we do is we'll make a little 1-inch incision in the knee, put this scope in there, and I'll hold it with my hand so I can move it around and see what I need to see. And I get this big TV screen that's showing me the inside of the joint. And I make another little incision, holding this, I'm watching, I use some scissors, and I cut that thing out through that little bitty incision. And I'm done. So it's an easy little procedure, that particular one, where in the past, to take care of that problem, it'd take 2 big old 4-inch incisions over the knee and about a week in a cast.
What's the recovery time on that?
Much faster with arthroscopic surgery. You know, back in the day, 30, 20 years ago when I first started this, it was nothing to leave a patient in the hospital for a week after surgery. Well, we found out that's wrong. You want to get the patient up and moving. The longer they stay in that bed, the more problems you're going to have with pneumonia, bed sores, blood clots, poor recovery, poor outcome. So we want to keep you moving along. Best therapy is to send them home and take away the remote control.
What is the history of sports athletes? Like, to me, your foot or all your elbow, you have just so many times you're going to do that, and it's going to wear out. Somebody that runs a marathon, to me, is crazy.
Yeah, I was. You had a question for me?
I have a friend that had total knee replacement this past week, not here. Within 24 hours, he had a major stroke. What is the percentage of that happening?
That is a very, she was saying that she had a patient, she has a friend who had knee replacement surgery and had a stroke. That is a very, very unfortunate incident, a very unfortunate problem. I'm sorry she had that. The incidence of that is very, very low. I mean, I've been doing it for 30 years. I may have had one person had a stroke.
Really?
Yeah. Now, I have had a couple of people die on me from blood clots. But that was a few years back before we have better ways to treat that now, better ways to prevent it. And I've probably been involved in over 5,000 joint replacement surgeries. A lot of them. And part of the thing,
percent is not very much.
no, it's very low. So what happened, I don't know, but I know what I do to help prevent these problems. I don't like problems. I want to go fix the knee, and I want you to go tell your neighbors what a great job I did and how much better you feel, right? So before I do surgery, when someone comes to me and says they want to have their knee replaced or their hip replaced or whatever, for major surgeries, I will give them a letter. And this is common. Most doctors will do this. They'll go see your family doctor. The family doctor will see you and evaluate you. And it's not a guarantee that you're going to do okay, but they're looking for potential problems. And I don't really know the patient's medical stuff. I know their bone stuff for sure. So I asked the family doctor to see them and check them out. Let me know if there's something else we need to do to get them ready. Once the family doctor says they don't see any reason why they can't have it done, I see the patients back in the office. I see them, talk to their family members, make sure they understand what we're going to do. They go get registered at the hospital. The morning of the surgery, we go in, and I do most of these surgeries under spinal, hip and knee surgeries under spinal anesthesia. It's been shown to give a better result, less pain after surgery, able to mobilize the patient without having to use pain medicine like morphine or the heavy stuff, Dilaudid. We found that it's best to get away from all those opioids. Not only you hear about the opioid epidemic, well, there's more than just that. We want to use them at all if we can. We don't want the patient in pain, but we want them up and moving. So that's why we move them along. Someone else. One more question. I have one more question.
Okay.
Maybe 2 or 3 more. Go ahead.
I was x-rayed and they said I had arthritis in my knee. Then my doctor tells me it's the way I walk, as it goes down my leg.
What she says she has arthritis in her knee and she has pain in her knee. Pain from arthritis is not due, it's from the arthritis. Now you may walk funny because of the arthritis, but walking a certain way doesn't cause arthritis as far as I know.
Right. I didn't think so.
Yeah.
I'm like,
Now I can tell you what, arthritis, if you have arthritis in your knee, sometimes it'll make a lot more than just your knee hurt. It'll come all the way up and down your leg and all over. It'll make you miserable.
outside.
Yeah.
I see a lot of the over-the-counter drugs, ashwagandha and glucosamine and chondroitin. Does any of that stuff help? Or?
That stuff, here's what that stuff is. The glucosamine and chondroitin sulfate. If you read the label, it says bovine source or something like that. Basically, it's ground up cattle cartilage. And if you eat that, it's supposed to make you grow more cartilage. I mean, you tell me if I cut off my finger and I eat more fingers, I'm going to grow a new finger. It's not true. Cartilage, as I said earlier, the hyaline cartilage is very precious, very complex. So far, once it's gone, it's done.
What can you do to keep it healthy? Anything?
Yeah, there are a few things you can do. What can you do to keep your cartilage healthy? For the most part, motion and activity is a thing the cartilage needs. Immobilization is one of the worst things you can do. Putting people in casts and all these things we used to do, hardly do any of that anymore. We found out it's bad for the knee or the leg, the whole body. Low impact activities, regular exercise, low impact. Elliptical rider is the way to do it, elliptical walker, swimming, biking, that sort of thing. Jogging and running marathons is probably not a great thing to do.
How about a little light jog? No? I used to run track with your brother.
Why you want to run? Someone chasing you?
Not fast, just more than a walk. Just a little, not fast at all.
You're going to trip and break your hip.
Oh, just walk back.
Just walk. Yeah, walking is the best. That's what the human body's made for, upright activities.
I've had both knees replaced. Left one about 6 or 8 years ago. I'm having extreme pain. I've had it x-rayed with the same physician that replaced it. I looked at the x-ray with him, saw no change from the day of surgery to 3 weeks ago. No change whatsoever. And I've had to been forced, I guess, because of pain, to use stuff like biofreeze or some of that, or I can't survive with the pain.
He's having pain after a knee replacement surgery. Surgery was 7 years ago.
Yeah,
right, okay. What causes pain in the knee or pain in a joint that's been replaced 7 years ago? Been pain-free for 7 years, now it's starting to hurt, right?
Right.
Okay. So there's a number of things that can cause that. First of all, just because you had a joint replaced doesn't mean you're not going to have a bad day here and there down the road. It can happen. I'll see people every once in a while, my knee hurts, the weather changed, and, well, eventually it goes away. It just hurts. I don't know what caused it. First thing you got to do if it's persistent is make sure the knee itself is okay. X-rays are the simplest, easiest, most accurate thing to do. A set of X-rays is good. You don't need to run all those expensive tests right off the bat. I'd probably treat it with some medication, see how it did, see how it goes. If they keep having pain, the most common, if the x-rays look good, there's nothing wrong with the knee, the most common reason for the pain is some other problem in the leg. Arthritis in the hip can do that. Sometimes you get some muscle issues that can cause some pain in the knee.
Well, he thinks it may be scar tissue, but what kills the pain or eliminates the pain is twice a day rubbing the biofreeze or something like that on it, and it's fine.
Yeah. Keep doing that, because when you see an orthopedic surgeon for persistent pain, we're looking for problems related to surgical treatment.
Right. see any either. I mean,
Yeah.
we didn't see anything relative.
Keep going to your barber complaining you're going to get a haircut.
How about Medicare? Does Medicare cover it?
Yes, sir. 80%.
Could I just make a statement? I didn't have a question. Of course, I had a different orthopedic surgeon to have my knee done because I never met you before. But that was in 2013. I was 287 pounds. Before he even said he would do the surgery, I was getting the shots, you know. He said, I will not put you under anesthesia unless you lose 50 pounds, which I did, and then I got on a roll and took some more. After the surgery, he said to me, every pound total weight on you is 4 pounds more on the knee, for every pound. So let's say if I weighed 200 pounds, that's 800 pounds on the knees. They're weight bearing. So he said, the thing I'm trying to tell you delicately, women don't like to hear this, keep your weight down.
Yes. It's actually 6 times. There's 6 times more your kneecap.
Today, like
Yep.
if I lift a 30-pound bag of dog food, well, it hurts. And then I say to myself, you know, I used to be much more than that. And you're carrying that weight around with you every time you're standing upright.
Well, thank you for sharing the story. That's a great way to end this talk, the total knee success story. All right? Thank y'all.